morning, everybody.
Good morning, Dr. Ole.
Good morning.
Please forgive me as I'm eating my Captain Crunch.
Is it crunch berries or peanut butter crunch?
No, it's just regular crunch with bananas. I needed some comfort food this morning. Sean's the one that eats peanut butter crunch. Ugh. Gross.
Yeah. One of my twins really likes the peanut butter crunch, but only if it's really soggy, and I don't do soggy cereal, so I have a really hard time with that one.
Yeah. All right. Well, I'm gonna come off camera so that you have the show
Okay.
in your massive space that you have. And
I know. I was trying to angle the camera, and I'm like, I just can't. There's just no space in here to angle. I mean, I'm already up against the wall. Yeah, it is what it is. So.
It is what it is. That's right.
Yep.
All right. Well, good luck. I'm sure you're gonna do great.
All right. So I do want to thank everybody who has joined us for the first presentation of our day today and our second day of our virtual conference. My name is Dr. Amy Crowley, and I am going to be providing a presentation today on the basics of harm reduction treatment. So for anyone who has taken or will take the addiction course here at CMHC Online, you'll get a little bit of information about harm reduction, but it is a fairly quick overview of it. And so today, I just want to kind of give a little bit more of an in-depth so that students and faculty are kind of introduced to what harm reduction is, as well as some of the basic tenets of harm reduction treatment. So I am also going to go off camera, and I will then share my screen and bring up the presentation, of course. So okay, so as I said, my name is Amy Crowley, and today we're going to go over the basics of harm reduction treatment. So some of our objectives for today are to learn the basics of harm reduction, to understanding what harm is as seen by the client, the 5 basic principles of harm reduction, the client's role in change, the stages of change, how to incorporate harm reduction into everyday practice with addiction, some special considerations and special populations. I'll also just remind you guys that I can't see you. Of course, you're off camera anyway, but I also can't see the chat box. So Dr. Hudson, if you're able to tell me if anything pops up in the chat box, I would appreciate it.
I will do that.
Thank you. And certainly if anyone has questions along the way, feel free to chime in and ask them at any time. So the first thing we're going to go over is what is harm? And so part of harm reduction treatment is understanding this as an approach to addiction counseling. And in order to participate in harm reduction treatment, we really have to understand what we mean when we say harm. So when it comes to harm reduction treatment, harm is anything that happens, no matter what causes it, that damages any part of you, your life, or those around you. It can be physical, it can be emotional, it can be social, legal, financial, or spiritual. And for some, this is a list that they're not always used to seeing too many options on. Sometimes they kind of think of physical harm in instances of, say, domestic violence, or emotional harm if someone or something has hurt their feelings. But when we review harm reduction, we really look at multiple facets of the client's life. Harm is relative. Some people are damaged in different ways at different rates from the exact same thing. So what I may view as being harmful, another person may not. So one of the things we'll talk about a little later in the presentation is how harm reduction is really a client client-centered approach to treatment and really gives the power to the client to define what harm is. The clinician's job is to kind of help and guide the client through defining that and reminding them that it can be physical, emotional, legal, spiritual, but really kind of giving the authority over to the client. It should be noted that engaging in illegal behaviors automatically puts the client at risk for harm. So understanding some of your local laws regarding the use of drugs and alcohol, whether it be the age that an individual can use. Certainly in the past 5 to 8 years, we've had various municipalities and states legalizing the use of marijuana for recreational or medicinal purposes. Some areas put age restrictions on them. Some places put restrictions on them based upon needing a diagnosis or a documented medical condition. So really understanding the confines of the law is going to be really important, because some of your conversations are going to be around whether or not a client is viewing the potential legal ramifications as harm in their life. So I do just want to remind us about hidden harm. And so sometimes harm is not noticeable, such as a person with hepatitis who drinks alcohol. So I don't want clinicians to get caught up in the, well, they seem to be fine. There doesn't seem to be any, noticeable medical complications from their behavior, yet an individual who has hepatitis who drinks alcohol is exacerbating their medical condition. Part of harm reduction, as with most addiction counseling, is to make sure that the client has undergone a very thorough medical evaluation, as the use of substances and even some addictive behaviors can cause very significant medical complications for them. So we want to make sure that we're attending to those as well. And so it says, what about the hidden harm that is difficult to see? So some examples I provided is maybe a teenager who has some discomfort in social situations. So maybe they drink in those situations in order to relax and feel as if they're fitting in with their peers. In these situations, they may never learn to be themselves or to be uncool around their peers. And so they can get tied into drinking as a means of socialization and not necessarily developing the skills necessary to socialize sober. So that's one of those harms that isn't necessarily physical harm or a financial harm, but it is more of an emotional and developmental harm. There's also an example here of someone who was molested as a child. They may like to space out and forget the abuse so that they discover that a drug helps them to space out even more. However, when they're not using, not under the influence of that drug, all of those feelings, emotions, memories come back. And so now not only are they addicted to potentially a very dangerous drug, but they also want to avoid all of these memories. So giving up that drug is even harder because they don't have coping skills to have learned how to deal with some of their past abuse. All right. Just to kind of put this in perspective, harm reduction is by no means new. It's something that we've had in our country for many, many, many decades. It's just that we haven't always labeled it as harm reduction. And so I wanted to kind of just put out there, because some people are very turned off by the idea of harm reduction, who find it to be very controversial. But in actuality, we practice harm reduction daily. So some examples of harm reduction are needle exchange programs. Different places may allow an individual to come in and exchange a dirty needle for a clean needle no matter what. There are actually locations, there's actually quite a few in Vancouver, where you can go into an environment that is clean and sterile and use needles and syringes that you find available there in order to prevent the spread of other diseases by using dirty needles or sharing needles. HIV and STI prevention through handing out condoms, and even PrEP, which is a medication that males who engage in sexual behavior with other males can take to help reduce the incident of HIV infection. Teaching abstinence in sex education. So many locations still take an abstinence approach to sex education, which is a form of harm reduction. Seatbelts are a form of harm reduction. Extended reverse-facing car seats are a form of harm reduction. Vaccinations are a form of harm reduction. Methadone maintenance programs, and even now buprenorphine or Suboxone. Teaching moderation management is a form of harm reduction. And then intoximeters and scram monitors that can be installed in either a vehicle or worn directly on an individual are also examples of harm reduction. So there are 5 basic principles to harm reduction. And the first one is that not all drug use is abuse, but harm can occur anywhere on the continuum. And the continuum of use is no use, experimentation, occasional use, regular use, heavy use, abuse and dependence. And abuse and dependence were previously DSM-4 TR, DSM-4 labels. We now use levels of severity to denote the degree to which the use of a substance or addictive behavior is problematic. And then the last on the continuum is chaos. People use drugs for a reason. Alcohol and other drug use is tied to some common difficulties. This is by no means an exhaustive list, but trouble with relationships, trouble with taking good care of oneself, trouble with handling strong emotions, struggles with self-esteem. Alcohol and other drugs are not always the cause of these problems. Sometimes these problems came first, and the alcohol and drugs are used to just self-medicate or soothe the pain. So this is kind of the age-old debate over what came first, the chicken or the egg. So are we experiencing emotional pain and we use substances in order to help deal with them? Or is the fact that we're using substances causing us to experience problems, emotional pain? And it says, just as we would not ask someone to remove the Band-Aid from their cut, we must not always ask them to remove their alcohol and drug use from their wounds until some healing has occurred. And this is one of the tenets that kind of goes against the typical abstinence-based training that often comes with addiction counseling, is this idea that you can't use any substance to any degree, that you're cross-addicted to other substances once you're addicted to one substance. And oftentimes an individual attempting recovery can feel very vulnerable to not have their coping mechanism anymore. So being told that, you can't ever drink again, you can't ever drug again, and now you have to start developing those coping skills, puts them at a period of time where they really are without that proverbial Band-Aid to cover their wounds. And that's why we see relapse occurring so quickly after someone may attempt recovery, because they don't have the skills in place in order to help them through that transitional time. The next is that it's a combination. Problems don't just come from drugs themselves, but from a combination of factors and circumstances. So we certainly have the drug, the specific drug of abuse, alcohol, marijuana, heroin, prescription drugs. This could also be a behavior that could be addictive, such as gambling, sex, eating, spending money. The set is the manner by which it's you participate in it. So if it's orally consuming alcohol, if it's injection drug use, if it's crushing and snorting pills, that in and of itself carries risk factors. So, pills are intended to be taken orally. Someone who crushes them and snorts them has now increased the risk simply based upon the manner by which they take the drug. Setting is the environment in which the drug or behaviors participated in. And so if it's everything from the behaviors one engages in order to procure their drugs, going to less safe neighborhoods, engaging in drug purchasing behaviors, maybe drug dealing behaviors, where are they shooting up? Where are they drinking their alcohol? Are they trying to hide it from others? So those settings can be very risky as well for an individual. It can certainly in and of itself cause harm. And then, of course, knowing that everyone is unique. So just because one person is at risk for drinking alcohol within their own home, maybe due to the feelings of others in the home about their drinking, maybe due to having a two-story home, and when they drink so much, they've been known to fall downstairs. It may not be the same for another person. So there's no real hard and fast rules. It's just knowing that a combination of these factors is certainly something that has to be considered. So the client is the expert. They are their own expert. The concept is the client evaluates their own readiness to change and their own progress along the way. So as I said earlier on, this is very client-driven. The counselor is there as a guide, but it's really up to the client to evaluate, are they ready to change? What are they willing to change? How much are they going to change? And then monitoring that change along the way. The client identifies where harm is occurring. So as the clinician, you might perceive there to be harm in multiple areas of a client's life, but if they don't perceive that, then it's not harm that you're going to address. At some point down the road, they may have some insight into it, but if at the present time they don't see it as being harm, then it's not harm that you're going to address. So the client sets the goals and works to achieve them. The clinician is simply the guide along the way. And then the fifth principle is that change is slow. Positive changes can be made while still using. And this is one of those things that's very hard for individuals who've been trained in abstinence-based recovery to conceptualize, is that you can still engage in using an addictive behavior and make positive changes towards recovery in that process. A user's life did not become chaotic overnight, though outsiders tend to view it this way. So you have to give clients time to work through things at a pace that is manageable to them. So, just because we may feel as if it's high-risk behaviors and they need to make those changes right now, if the client is not at a point where they're willing to agree to that, then they're not likely to be successful in treatment. Clients tend to be less turned off by the idea that they do not have to give up everything right away. So in a typical abstinence-based program, clients will be told that they can no longer participate in any of their addictive behaviors again. But that can be really hard for a client to feel like you are now taking over the control and they no longer have a say in that. So some of the primary advantages of harm reduction is that a client trained in both abstinence and harm reduction shows increased commitment to abstinence over the long period of time because they don't feel forced to stop. So, I do just want to say that harm reduction isn't anti-abstinence. Abstinence is certainly a goal that a client can set. It can be a goal that they set from the beginning. It can be a goal that they set partway through. But we're not anti-abstinence by any means. We are just willing to accept that change is better than no change at all, or as we'll learn in a little bit, failure in programs because a client isn't able to maintain that complete abstinence. So some important things to consider is that you do have to consider the continuum of drug use, drug by drug. So just because someone has problematic use of alcohol doesn't mean that they necessarily have problematic use of marijuana. And so we really want to be cautious not to, lump someone into a category of being in chaos, certainly simply based upon their use, their setting of one particular addictive behavior. A person's use of each drug will not remain the same over time. So, clients don't wake up one day and start shooting 8 bags of heroin. They build up to that. And they might have periods of time where they're able to reduce their use on their own, even without intervention, without treatment, without knowing about harm reduction. Same thing goes for the use of alcohol as well as addictive behaviors. So a person may not always engage in the exact same frequency, duration, or amount over a period of time. And it also says that a use of substance will not automatically progress to severe, even if the person gets into trouble. And severe is one of those DSM-5 labels in terms of severity of use. So really understanding that while trouble might come in the form of health and legal, relationship, financial, employment issues, those problems can still occur in someone's life, even if they haven't made it to severe, even if they have, maybe only been in the experimentation phase, they can still have trouble. So we also don't want to get stuck in the binary of feeling like a client either isn't using or their use is severe, and that's the only time they're going to have negative experiences or harm in their life. Some special considerations are that as age increases, metabolism decreases. So when someone's able to consume a certain amount at a younger age, they're not going to be able to consume the same amount as an older age. It is important to consider the age of first use, and this has to do with the brain's development and the introduction of chemicals and how they hinder the development of emotions, cognitive functioning. Gender and race have a lot to do with some of these special considerations. We have certainly trends that have been researched in the field according to gender and race, and we want to pay attention to the culture of the client and how that has some impact on what may or may not be considered harm. An individual who may be pregnant or trying to conceive or even have small children, those are things that we want to make sure we're bringing up when talking to clients about harm. Certain diseases and infections such as HIV, hepatitis, and diabetes. The social climate of the client. So teenagers and college students where use of substances may be more socially acceptable. It may also, I've had clients over the years who've had jobs where socializing around alcohol was prevalent. I've also had clients who socializing around food was an expectation, and they may have some addiction issues related to eating and food. And then there's a risk involved simply in procuring illicit substances as well as consuming it. So while there's certainly the legal ramifications of purchasing drugs, there's also the manner by which one it takes them into their body, be it oral, be it inhalation, be it injection. So that in and of itself carries risk, and certainly higher risk for some over others. So some core concepts is we're not debating why people use or continue to use substances. We're simply accepting that this is going to happen. So we don't get wrapped up into the why can someone not stop? Why is relapse occurring? We know that this is a difficult process, and we're trying to find an alternative way to approach recovery for these individuals. We assist our clients in making better choices about their use rather than directing them only towards abstinence. So we really do teach clients about ways to reduce harm, to live a healthier life, to take better care of themselves, rather than just saying the only answer is abstinence from your substance or behavior. And then we have research that shows that tough love does not usually work, but that we do understand that it's important that limits are set. So in the beginning, when working with a client on harm reduction, you want to start with education and training, including all options, abstinence being one of them. So you start with your client, you teach them about harm reduction, you talk to them about various ways that they can change their behavior, identifying harm, and of course, abstinence being one of the potential goals. So an example is, don't have premarital sex, but if you do, use a condom to prevent STIs and pregnancy. So that would be kind of an intro to utilizing harm reduction with someone. Discuss the pros and cons of their current behavior, really encouraging the client to explore what they get out of their behavior, what the positives are, what they see the negatives are. I had a client quite a few years back who had 7 DUIs, which seems extreme to me, but to this particular individual, there was no difference between 1 DUI and 7 DUIs. A DUI is a DUI, and once he had one, it didn't seem like a big deal to get more than one. And so at that point, he had kind of moved beyond the I'm taking a risk by driving under the influence to saying this is just how I am. So it took us a little bit of time to kind of get him to a point where he was starting to evaluate that behavior as being risky and harmful, something he needed to change. Your first goal should be to stabilize the presenting problems and prevent any further harm. So certainly we want to correct some of the past harms, some of the outstanding harms, but we also want to work with our clients to not continue to expose themselves to new harms or increasing harm. And so again, an example is just as you would put a neck brace on an accident victim, you need to stabilize them in the present before moving on to changes. So then the client's presented with a dilemma, and the choices are to change or not to change. The client can change something, they can change everything, they can change nothing. It really is their choice. But in doing so, the client has to weigh the costs and benefits of both sides. And so this really does take some time to sit down with the client and kind of discuss, write out, chart, whatever manner works, the pros and cons to changing, not changing, what they might want to change, what they feel most comfortable changing. So some things that can change are they can change everything. They can keep they can eliminate one drug and keep the others. They can eliminate more than one of the most harmful drugs and keep the rest. They can switch from more harmful to less harmful drugs. They can change how they use, how often or when, or even where. They can change elements of their addictive behavior. For example, maybe they used to drink Red Bull and vodka. And so while they may not be ready to give up the vodka, maybe they're willing to change from Red Bull to cranberry juice. And while that might seem like a minor change, it's an interruption into their old behavior pattern. So any change is celebrated in harm reduction. And then, of course, they have the right to not change. They can accept themselves as a user and embrace their ambivalence about their use. They can find people who accept them in that way, especially if they're experiencing relationship struggles due to their addictive behavior. They can educate themselves about safer use of drugs. They can pay attention to themselves when they're under the influence of drugs or alcohol or other addictive behaviors, including kind of evaluating what it is that they're doing, how they're behaving, how it changes maybe their emotions, their attitudes, their approach. They can spend some time pondering what they're using or engaging in addictive behavior for. They can do other things to be healthy and balanced in their life, things like eating healthy, exercise, sleep, spiritual health, relationship health. These are all things that are leading towards change in their life, even though it may not be a specific change related to their addictive behavior. And then also, if they're using within their means, both financially and emotionally, that then can help reduce the financial and emotional harm, but doesn't necessarily change whether or not they're using or participating in an addictive behavior. So real quick, just kind of a review of the stages of change, knowing that clients will have to move through this. They may have to move through it multiple times. They may have to revisit some of the stages. They may have to go through the stages of change with each and every addictive behavior. The first one being pre-contemplation. This is often the stage that is paired with not really acknowledging that there's even a problem, maybe not acknowledging the severity of the problem, maybe still very much in denial. Contemplation is the acceptance that there's something going on. There's something there, there's something we need to address, and they know that something has to change. Preparation is the kind of development of the plan. What am I going to do? This is typically where the majority of the work with a counselor comes in, is, what am I comfortable changing? How am I going to change it? What are my specific action steps? How am I going to monitor it? And really preparing themselves for that. Action is taking their plan and putting it into action. I'm going to go out and I'm going to actively work on these changes. Once clients kind of figure out what changes that they're comfortable with and can stick with, they get into the maintenance phase. Maintenance is where they're continuing to participate in harm-reducing behaviors, on a consistent basis, and not necessarily going back and revisiting the preparation and action phases again. The next is relapse. And one of the big differences in harm reduction versus abstinence-based treatment is that we understand that relapse will occur, but it doesn't equate failure. So in an abstinence-based program, if somebody relapses and participates in their addictive behavior again, it's considered a failure of their recovery. Well, that can be very difficult for clients to feel like they're failing, especially if they're a chronic relapser and they feel like they're failing over and over again. So in harm reduction, we understand that relapses are likely to occur. And what a relapse means is that we need to go back and we need to revisit the preparation stage. We need to look at our plan and figure out what didn't work in our plan and create a better plan. And then termination, and termination and harm reduction means harm-free, but not necessarily drug or addictive behavior-free. So when working with a client on deciding what to change, some important questions to ask are, what is necessary to change? What is manageable for them to change? What is tolerable for them to change? And you may find that there's some conflict. So a client may know that it's necessary to change their smoking of crack cocaine and purchasing of prostitutes. That's something that is causing them significant financial harm and causing them relationship harm, and they're able to see that there's some potential legal harm related to that. Is it manageable? Well, depending on the reason why this individual may use, they may find it unmanageable to say, okay, wait a minute, I'm not really ready to change my use of a substance because that helps me cope with my emotions. But maybe it is manageable to change their purchasing of a prostitute. And then what is tolerable? So they may have the best of intentions, but maybe through planning or even putting their plan into action, they're realizing that it's not tolerable for them to make that change. So they have to learn to compromise with themselves. And we often remind clients that if nothing changes, nothing changes. So it's important to change something, no matter how small it is. And that kind of goes back to my example of an individual who may be drinking Red Bull and vodka and switching from Red Bull to cranberry juice. A very small change, but at least we're working on change. Some important reminders is that it's not what you use necessarily, but how, when, where, how much, and with whom you use that contributes to either harm or safety. So when we really start exploring with clients, it's not just that they take prescription medication in ways that it's not prescribed for them, but maybe it's that they are crushing and snorting the pills. Maybe it's that they're taking them more often than the doctor prescribed, even if they're taking them orally. Maybe it's the environment that they put themselves in when they're using. Maybe it's the number of times that they participate in a behavior, or the people that they put themselves around. Those are the things that can also cause harm, and we don't want to overlook them when planning harm reduction with clients. So substance use management is a sort of the maintenance or the action and maintenance phases of harm reduction. And this relies on the client's ability and willingness to observe themselves. So, as a therapist, you're not sitting with your client while they're continuing to engage in this addictive behavior while reducing harm. We really rely on the client's ability to monitor themselves and come in and report back on success or not success with their plan. Because clients are not shamed for relapsing, because the expectation and understanding is that clients may continue to engage in these high-risk behaviors. Clients can be more open about their success and lack of success in their attempts to make change, because they know they're not going to get in trouble for relapsing or continuing to use. So the client and only the client's responsible for what they put into their bodies. And really kind of reminding clients that it's not our job as counselors to make them change, that they have to choose the change that's manageable for them, and be willing to make these changes. So a client has to be honest with themselves from the beginning. And as a counselor, it's really your job to help clients explore what their addictive behavior is causing in their lives. The client has to be willing to make some changes. So even with abstinence-based treatment, if a client is unwilling to make changes in their life, they're not going to be successful. And then they have to learn the skills needed to make concrete beneficial changes in regards to alcohol and drug use. And this is where the time that they spend in counseling, being educated on harm reduction is really helpful. So some examples of change clients might make is they might change the amount that they use, they might change the route of administration, the number of drugs used, the frequency, their situation or surroundings, and they might use a substitution. And an example of a substitution would be methadone or buprenorphine for our opiate addicts. Some other important things for clients to remember is they need to take care of themselves throughout this process. They have needs of their body. They have to be eating well. They have to be staying hydrated. They have to be staying warm. Maybe if they're located here in Florida, they need to be staying cool. Their safety is a need that has to be met. They need to be, working towards adequate sleep. And then pain management. And this is one that initially was not part of harm reduction, but has been added in to look at both physical and pain management. As we've seen increased rates of individuals becoming addicted to opiates, they were prescribed for the management of chronic pain. And so one of the difficulties those individuals often have with changing their behaviors is that they need to find alternative ways of managing their physical pain. They need to be taking care of their mind and emotions. They need to be taking care of their overall brain functioning and brain health, as well as working and counseling on any negative thought patterns that they have, beliefs that they have about themselves, maybe messages they've received from others regarding who they are as a person, as an individual, especially with a history of addiction. And then, of course, they need to be taking care of their spirituality, their soul, their whole being. It's very much a holistic approach to recovery. So as the client's working on change, when they come in for session, they'll be evaluating if this change is working. So progress forward may include taking breaks along the way, or may even include some setbacks. And that may be part of a pre-prescribed plan of change. It may be something the client is actively working into their plan, or it may be that they've made some changes and future changes seem unmanageable or intolerable. So for now, they're going to maintain where they're at. It's really important as a clinician you don't let your client give up, and that you don't give up on your client. So often we have reports of clients who go into abstinence-based programs and feel like because they're relapsing and they're having to return to treatment, that people are getting fed up with them for this, that people are, viewing them as hopeless, that they won't be able to make the lasting change. And it can be very discouraging for someone who's actively working on changes, but these are very powerful addictions, very powerful substances, and it's not just as easy as not doing it. It may take days, weeks, months, even years. It's also important when possible to work with the family. You really want to educate the family on what harm reduction is, because oftentimes they believe that the person just needs to stop. And if the person isn't stopping everything all at once, they find that the person isn't working on recovery. So as much as you need to educate the client, sometimes you need to spend time educating the families and support persons in that client's life. And harm reduction says that as long as you remain in contemplation, preparation, action, or maintenance stages of change, then harm reduction is working. So if you enter the relapse and as a clinician, you're trying to get your client back into contemplation and preparation, and they are not willing to work there, then harm reduction may not be working for them. If they understand that relapse occurs and they're willing to revisit their plan and make some revisions, then they're still actively working in harm reduction. So clients need to be thinking about their relationships with substances and addictive behaviors. They need to be realistic about the harm that is occurring, and explore why they're participating in these behaviors. The client needs to set goals. It's important as a clinician that you're aware of what your client wants and needs, excuse me, so that you're not leading them down a path that they're not in agreement with. So you really want to be revisiting with your client, what are their goals? What do they see as their end result? Where is it that they want to be? I've worked many times with young adults specifically who know that maybe their drinking at parties has gotten out of hand, and they don't want to spend their entire life abstinent from alcohol. They just want to learn how to drink in moderation. And so if I constantly push them towards abstinence, it's not going to be effective for them because that's not their end goal. If I encourage them to continue to attend parties and drinking at the manner by which they are, it's again not reaching their goal. So really understanding what your client's wants and needs are. And then of course the client needs to make changes that they can live with. Managing their use or participation in addictive behaviors better, doing less harm to themselves, constantly developing those new goals, and then really learning to take the positive comments from others. Individuals that are not educated in harm reduction can be very negative towards someone who's working on making change and reducing harm because they don't see it as being successful because it's not abstinence-based. There is still a lot of misinformation about harm reduction in the field, and so there's a growing acceptance of harm reduction. We still have 90% of treatment programs in the United States that focus on abstinence only. So as a reminder, we aren't anti-abstinence. We recognize the need for abstinence and see it as an ideal outcome, but we also know that there can be alternatives for our clients that reduce harm in their life. It's emerged primarily as a bottom-up approach based on addict advocacy rather than a top-down policy promoted by drug policy makers. So harm reduction is not universal. It's practiced more internationally than it is here in the U.S. So those few locations, those few treatment programs, those clinicians that are trained in harm reduction and believe in harm reduction really work from a client advocacy perspective and educating clients, educating referral sources, educating families about the effectiveness of this. Whereas an abstinence-based program kind of comes with societal acceptance because it's what they've always known based upon program structures and policies. And harm reduction really is more about compassion versus morals. So this isn't about a client being unwilling to or unable to reach abstinence. It's about kind of retraining them to be kind to themselves through the change process, as well as you as a clinician being empathetic to the client's efforts to really make these changes. So I just want to real quick kind of touch on rock bottom. Oftentimes in the addiction field, you'll hear that somebody has to reach rock bottom in order to make changes. But in harm reduction, there doesn't have to be a rock bottom. What we're really looking for from clients is just a recognition that there's harm in their life of some nature and a willingness to change that harm. So they can begin to practice harm reduction at any point as long as they're willing. They don't have to be bad enough off. They don't have to experience worse consequences before they're willing to make a change. They just have to be willing to make a change. And the client has permission to take their time. They're on their own schedule, but they have to understand that ultimately the law will prevail. So specifically when we're looking at the use of illicit substances and some addictive behaviors, we have to remind clients that while they may be actively working to reduce harm, this process does not erase established laws. And so they need to take those into consideration when deciding what it is they're willing to change and where they are willing to reduce their harm. Harm reduction is also a great opportunity for advocacy. So those that believe in harm reduction say that there may need to be some changes in the laws to reflect this concept. Advocating for clients from that bottom-up perspective is certainly one step. There can also be advocacy steps taken to change drug policy, and part of that occurs by just like today, and educating other people on what harm reduction is, kind of challenging the myths about harm reduction so that individuals can gain a better understanding for why success rates in harm reduction are higher than success rates in abstinence-based programs. Drug courts, which support treatment and not incarceration, are a great place for implementing harm reduction. And then, of course, educating law enforcement officials on this concept, that people are not bad, it's what they put into their bodies that's bad. And so I've had some success over the years working with local probation, parole, and law enforcement agencies to really kind of help them see that the moral model, the abstinence-based model of recovery is not the only way that individuals will make lasting changes in their life. So we had said earlier we would talk a little bit about some special populations, and HIV positive clients are one of those populations. In fact, the government sets aside additional grant funding for treatment for individuals who are HIV positive, and that's due to the high correlation between HIV/AIDS and drug use. HIV positive users need to understand how their use affects their HIV status, including their the effectiveness of any medication they may be taking to combat their HIV, as well as just their overall health and well-being. And drug use may also impact their compliance with HIV medication. So sometimes having conversations with clients about if they're prescribed medication, are they taking it, is one of the first steps. And then drug use may influence the attitude and spiritual connection that clients have regarding not only their medical condition, but the potential they have for change. Some other special populations, some cultural considerations are things such as the prevalence of alcohol use in the Native American community. So when we're dealing with cultural concerns, we need to take those into consideration when talking to our clients about change. And certainly a client who wants to change their behavior, in this case, someone of Native American descent who is struggling with alcohol use or sees that alcohol use is causing harm in their life, may be up against some societal struggles where the community in which they live, the culture in which they engage, continues to support the use of alcohol. As well as the same individual may be less willing to change their alcohol use because it is an important part of their socialization. So this is another reason why harm reduction can be effective, because when we take into account cultural considerations, it isn't a one-size-fits-all sort of program, as abstinence-based often can be. It does allow us to take into consideration some of those cultural considerations. Historically speaking, the Black community has experienced a lot of additional harms caused by geographical location, socioeconomic status, the view of law enforcement when it comes to those of minority status. Another special population is women with children in the home, and the safety of those children. Individuals with and without legal involvement. So keeping in mind that those that are already on probation have some very strict considerations they have to make for potentially violating their legal status. Pregnant and breastfeeding women, and the potential to transmit substances to their infants. And the LGBTQ plus population, specifically the high rate of alcohol use as a means of socialization amongst this population. And so this is just kind of a quote to wrap us up today, and it's from one of the harm reduction researchers that kind of is a forefather of our field, and that is that harm reduction places engagement of the individual in a potentially healing, self-affirming relationship at the forefront of any intervention, and that's what good psychotherapy has always been about. So I know that was a very quick kind of run through of a lot of information. So I'd like to just take the last couple of minutes and open it up to questions.
Has there been a lot of pushback, I guess, from 12-step programs, or like how has harm reduction kind of like been taken by a lot of 12-step programs, especially the traditional ones?
That's a great question. Moderation Management does conduct kind of their own version of 12-step meetings, which are accepting of continued use in the process of reducing harm. Typically, individuals that are working in harm reduction would not be accepted at our traditional 12-step meetings because the kind of premise behind those is that you're giving up whatever your addiction is. And so while an individual may be actively working to give it up, 12 steps are abstinence-based and operate on an understanding of relapse as having to start over. And so clients can find it very discouraging to go to a traditional 12-step meeting and feel like they're actively working on change, but that their peers in these 12-step meetings don't recognize that. Any other questions?
Could there be legal ramifications for the counselor in this? I mean, because to think about Florida, let's just say the Baker Act law, looking at harming yourselves or others by using this drug use, it could legally be argued that you are allowing them to continue to harm themselves. Is there any legal ramifications for that counselor who is, trying to work towards harm reduction?
That's another really good question, and you kind of used one of those key words is the counselor allowing the client? We are not allowing the client to continue to use. We are aware that the client is using, much like a counselor working in an abstinence-based program may know that their client continues to struggle with relapse. We are not giving them permission to use. In fact, our entire goal is to help them reduce the harms in their life. If you review your code of ethics, that's one of the ethical responsibilities of counselors is, kind of like the Hippocratic Oath for doctors is to do no harm. We are really working towards helping our clients to live better lives while also, practicing this idea of autonomy and having clients to really have a hand in what is occurring in their treatment. But we don't give permission to use. We're not telling them it's okay to continue their use. What we're doing is encouraging change related to that use. A therapist's knowledge of continued use can only be held over into the legal ramifications if you have direct knowledge that your client's actively driving around under the influence of alcohol and you haven't taken steps to sort of intervene. Here in Florida, we do have the Marchman Act, which allows us to have a client involuntarily admitted into treatment when it comes to addiction-related issues. But the likelihood of you having that direct knowledge of a client actively out drinking and driving is rather slim. Of course, unless they come to your office under the influence. And that would be no different than an abstinence-based program where you would have a responsibility to protect your client as well as others in that particular instance. Certainly in abstinence-based, in harm reduction treatment, we're not absolved of our responsibility for monitoring our clients for suicidality, homicidality, self-harm behaviors, but it's really a redefining that simply using a drug is not necessarily self-harm behavior unless the client is doing it for the actual purpose of causing themselves more harm. So it really is about defining the purpose behind the behavior. If you think about it, a lot of clients who aren't in substance abuse treatment of any kind, or even those who may be in abstinence-based programs, are still actively using on a daily basis. It's just that either they're not being honest with the program, they haven't gotten caught in their behavior yet, or maybe they haven't had enough contact with professionals in the field who can intervene. But it is a good question, and certainly when a clinician goes through harm reduction training, they will talk at length about the importance of documentation of your sessions and the client's process towards identifying harm and their self-reported behaviors of continuing to what degree in their addictive behaviors.
All right, thank you so
Any
much,
other-
Dr. Crowley. I have
Sure,
one.
no
I just have one question for you, and I know we're running really short on time. For
Sure.
those students that were really interested in the presentation, what would be some additional resources, or what would be next steps for them if they want to continue to grow in this area?
Sure. I have a kind of a summary sheet that I provided to Natasha with some harm reduction basics on it, as well as a resource list. And at the bottom of that resource list are some websites where you can go and kind of learn more about the basic tenets of harm reduction. Questions like 12-step support for harm reduction and how to go about finding harm reduction therapists. There is a credentialing process that one can go through to become a certified harm reduction therapist if it's an area of focus that they want to have. And that resource is also listed on that reference page that I sent in.
Okay, great. And that'll be available to all of you in the advising forum. It's going to take us probably a couple of days to get everything together and post that for you. Thank you again, Dr. Crowley.
Thank you so much. I appreciated the time.
All right. Okay, so our next presentation that'll be coming up is, let me see what it is. So we have two. We have the Clinical Supervision 101, which will be in Colleen's Blue Jeans room, and you'd need to go back and click on the title to get there. And then the Intersection of Eating and Substance Abuse Disorders, which is here in this room. And that one is Dr. Tiffany Rush-Wilson. So if you want to hang around for that one, you'll be able to enjoy that presentation as well. Thank you. Dr. Rush-Wilson, I think you're here, correct?
I am here.
Okay, great. And I know you're co-presenting, and I'm sorry, I need to look, and I don't know your co-presenter.
Oh, Susie Schnell and
Oh,
Rebecca.
Susie. Okay, perfect.
And Rebecca, although it looks like a C is missing from her name on the top.
Okay. Okay, I'll make sure to correct that for her.
Now, the PowerPoint is in box. Did you see that? Oh, hi, Rebecca, with two C's in your name.
Hi, Rebecca.
Hi.
Yeah, I'll go in and look. Do you need me or you or Rebecca? Are you guys going to run the presentation yourself, or do you need me to flip through the slides for you?
It doesn't matter. Do you want to flip through the slides? Did you want to stay?
Well, I was going to stay, so
Okay.
I can if you need me to.
Sure.
Okay. All right, I'm going to stop the recording.